Good afternoon everyone. So the next topic that we are going to start, it is the drugs which are used in treatment of gout. So this part is also comes under autocoids, and some of the drugs that we have already studied, the same drugs are there in this. Okay. So gout, the contents of my today's presentation are as follows. The first point that we are going to study is the gout general consideration of it. Okay, so what is gout, then why it happens, brief introduction we are going to give, then drugs which are used in treatment of gout, then drugs which are used during acute stage of gout, then drugs which are used in long term therapy of gout. In that, the two category of drugs we are going to study. The first category is drugs preventing synthesis of uric acid, and second category is the drugs which excrete uric acid. Okay, so let's start. So gout general consideration. So gout is a metabolic disorder which results from increase in body pool of urate, and it comprises of arthritis which is due to a reaction to the deposition of MSU in the joint. MSU stands for monosodium urate. Okay, so it is acute, recurrent, monoarticular, at least in the initial years, and usually involves peripheral joint in the lower limbs. Okay, so from the sentence we can get the points as it is a acute condition, then a recurrent means frequently is occurring, then monoarticular means a single joint is involved, and this single joint is involved in initial years. Okay, so as time goes by, the other joints will also be involved in this gout condition. Then also it involves the peripheral joints, so the lower limbs, they are mostly affected in this particular condition. Then second point, the painless deposition of urate crystals in the soft tissues such as cartilage, bursae and the tendons will occur. So these urate crystals, they may get deposited in these soft tissues like cartilage, bursae and tendons, and this deposition is painless in nature. Okay, so why deposition occurs? Simple, the metabolism of this uric acid. Okay, so this what happens due to this, that there is increase in the concentration or quantity of the uric acid in the body. So this extra uric acid, it gets deposited at various places, and one of the place is in the joints, as well as second place it is mentioned over here in the soft tissues. Okay, so next is the development of tophi or toffee, whatever you say. Okay, so in the later, after many years of recurring gouty arthritis, tophi may not be seen clinically but are often diagnosed radiologically. Okay, so this occurrence or development of tophi is the characteristic feature of the gout disease, and it can be identified or it can be diagnosed with the radiological test, like simple x-rays can also reveal the presence of tophi in the soft tissues. Okay, so next is renal calculi and the nephropathy. Renal calculi, that is kidney stone, and the nephropathy, it is disease of the kidneys. So the first episode of the acute MSU gouty arthritis many times begins at night with dramatic joint pain and swelling which mimic cellulitis. Okay, so less commonly the arthritis may be less severe and more indolent, and it involve more than one joint at one time. Okay, so what is said over here, it is that at night there is dramatic joint pain is felt. In daytime it will be less likely that the person suffering from the gouty arthritis will have the pain, but at night the pain will be severe. Okay, and also at the joints there will be swelling, and the swelling which occurs at the joint, it will look like that of the cellulitis. Okay, so the incidence of gout, it increases with serum uric acid level and the duration of hyperuricemia. Okay, however, hyperuricemia per se does not confirm or exclude the diagnosis of gout. So this sentence is very much important. Okay, what is thought that if there is increase in the uric acid levels in the body, then it will give rise to the gouty arthritis, but it is not always we can not always correlate exactly the cause and effect relationship between the hyperuricemia and the gout. It will also happen that there is presence of hyperuricemia, but there is no gouty arthritis disease signs and symptoms. It may happen. Okay, so that's why we cannot exactly say that if there is hyperuricemia there will be gouty arthritis. Okay, so hyperuricemia is necessary, but it is not sufficient for the development of gout. Only about 5% of patients with the hyperuricemia in fact ever develop gout. So understand, the only 5% patients with the hyperuricemia, they are predisposed or they may develop gout. Then what about 95% of the patient with the hyperuricemia? There is no probability or there is no chance that they will develop gout. So for development of gout, some other factors, they are also essential. Okay, so hyperuricemia is due to either increased urate production or decreased urate excretion. So two reasons are there that can lead to the hyperuricemia. The first reason is the increased production of the urate crystals, and second reason is its decreased excretion. In both of the ways there will be deposition of urate crystals or increase in the accumulation of uric acid in the body. Okay, so it may be primary or secondary to renal impairment, consumption of certain drugs, then massive lysis of cells during cancer chemotherapy. So there are certain conditions that may give rise to the hyperuricemia, like in renal insufficiency, that is the kidney is unable to excrete the uric acid. Then second, certain types of drugs, they are causing the increased production of the uric acid or decrease excretion of uric acid. And third reason that can give rise to the hyperuricemia, it is excessive lysis of the cells during cancer chemotherapy. Okay, so next is only about 10% of patients with primary gout overproduce urine. Okay, so primary gout means what? By themselves they have this gouty arthritis. There is no any other disease condition that is giving rise to the gout. It is the gout that is the first disease that occurs in that patient. Okay, and only 10% of the patients, they show presence of excess of urate production in their body. Okay, So majority of the patient, they have diminished fractional renal clearance of urate in spite of normal overall renal function. So in most of the patients who have the primary gout, they show presence of decreased excretion of uric acid. Okay, there is no problem with the production of uric acid, it is almost normal, but there is problem with its excretion. Okay, in humans who genetically lack an enzyme, that is uricase, urate which is less soluble, it circulates as such in the plasma. Okay, so the enzyme uricase, it makes this urate more soluble. Okay, but if this enzyme is absent by some reason, like the genetic reason, there is probability that the urate will be, whichever will be formed and whichever will be formed after certain metabolic reaction, it will be less soluble. Okay, in MSU gout, the patient has uric acid pool which is several times that of the normal. So asymptomatic hyperuricemia, where serum urate is greater than 6.8 milligram percentage, does not warrant drug treatment. Okay, so asymptomatic means what? There are no symptoms of the hyperuricemia, and where the serum urate level greater than 6.8 milligram percent. Okay, so this value can be found with the some pathological test. Okay, so in this condition, we don't need to give any kinds of drugs. Okay, but one should not ignore asymptomatic hyperuricemia, as it is associated with increased risk of hypertension, cardiovascular diseases, diabetes, CKD, that is chronic kidney disease, and all causes of mortality. Okay, so even though we are not giving any drugs for the treatment of the asymptomatic patients, but we need to be very careful, as this increased uric acid levels in the body, it can give rise to, or it can create many problems such as the cardiovascular disorder, then kidney disorder, and also can lead to the mortality, that is death. Okay, so hence the correction of the reversible risk factors such as obesity, hyperlipidemia, excess alcohol consumption, then high purine diet, that is meat and fish, and drugs known to cause hyperuricemia is wise. So certain factors we have to correct so that there will be no built up of uric acid in the body. So drugs which are used in gout. So there are three types of drugs. So the first type is helps to treat the acute gouty arthritis, and we have three drugs in there. That is the first one, that is colchicine. Second one is NSAIDs. In yesterday's lecture we have covered this particular topic. And the third one is the corticosteroids. So colchicine, it is a specific slow acting and it does have adverse effects. Then NSAIDs, they are short acting such as ibuprofen and indomethacin. They are non-specific, they provide rapid relief, and they are better tolerated when compared to the colchicine. Then corticosteroids, they are effective intra-articularly, that means into the joint. They have the most effects, and systemically also they are potential for rebound inflammation and adverse effect. It means that once you stop taking the corticosteroids, there is possibility that inflammation will reoccur, and also these corticosteroids, they have certain adverse effects. Okay, so next category of drugs is to prevent acute attacks of the gout. So in that, again the same two drugs, that is colchicine and NSAIDs, they are to be used. So the colchicine, it is effective in a dose adjusted not to cause diarrhea. Okay, so the NSAIDs, they are less well tolerated for this particular purpose, but may be used if colchicine alone is not sufficient to prevent frequent acute attacks. So the primary line of therapy in treatment of the acute attacks is the colchicine, and if colchicine is not sufficient to prevent the acute attacks signs and symptoms, then we have to add NSAID to the therapy. So NSAID becomes the secondary line of therapy. So the third category of drugs, they use to lower the serum urate levels. Okay, so we have probenecid over here. So it is a well tolerated drug. It interferes with excretion of many drugs. Then there is probability of urolithiasis. Then uricosuric, it is reversed by the salicylates. Okay, uricosuric means what? It is excretion of uric acid in the urine, and that is being caused due to the probenecid. But if we give aspirin along with the probenecid, then whatever beneficial effect of the probenecid, it will be reversed by the use of this aspirin. Okay, then allopurinol, what it does, it inhibits uric acid synthesis. So once a day dosage, it increases convenience. Then excretion impaired in the renal insufficiency. So what it means, the last sentence is that if there is presence of any renal disease in the patients of the gouty arthritis, then in that case we should either decrease the dose of allopurinol or we should avoid taking allopurinol altogether. So the next drug is sulfinpyrazone and the benzbromarone. Okay, so they are less commonly used drugs when we compare it with that of probenecid and allopurinol. So in acute stage, drugs which we use, that is colchicine, indomethacin and glucocorticoids. So colchicine, the first drug we are going to study. Colchicine is an alkaloid which is obtained from autumn crocus, that is colchicum. So it is a highly effective and specific for the treatment and prevention of acute gouty arthritis. So mechanism of action: sodium urate crystals in joints, they are coated by either anti-urate IgG antibody or lipoprotein which is containing apolipoprotein B, and then it is ingested by granulocytes. The latter then release a glycoprotein which amplifies neutrophil infiltration into the joint. Okay, so I will again read: sodium urate crystals which are deposited in joints, they are coated by either anti-urate IgG antibody, okay, or lipoprotein which contains apolipoprotein B. Okay, so these urate crystals, they are coated, they are covered with the either of the two things, that is anti-urate IgG antibodies or the lipoprotein. Okay, and these coated urate crystals are ingested by the granulocytes, they are eaten up by the granulocytes. So once they are ingested by the granulocytes, it causes causes its degradation, and it releases a glycoprotein which is responsible for the immigration of the neutrophils. That means the neutrophils, they do come into the, or they come into these particular joints. Okay, so by binding to tubulin, the colchicine, it damages the microtubules in the granulocytes and it interferes with the mitotic spindles. So thereby it inhibits migration of cells into the inflamed area. Thus it prevents intra-articular release of the mediators of inflammation by neutrophils. Okay, so simple, whatever we have written, I will just forget that. I will, in a very simple language, I will tell you that what colchicine does. It prevents neutrophils from entering into the joints. Okay, so by preventing the entry of neutrophils, it prevents further damage to the joints. This damage is actually caused by the various mediators of inflammation which are released by the incoming neutrophils, and as neutrophils they doesn't come or they doesn't invade the joints, they don't release the mediators of inflammation and there is no further damage to the surrounding tissue. Okay, so it also inhibits mast cell release of the histamine. It does not prevent phagocytosis of the urate crystal. So understand what it does and what it does not. So it won't prevent the phagocytosis of these coated urate crystals, but it will prevent release of the mediators of inflammation by the neutrophils, and also it will prevent the release of histamine by the mast cells. So pharmacokinetics, the oral absorption is variable, then it is 50% protein bound and it accumulates in the kidney, liver and the spleen. It undergoes hepatic enterohepatic circulation. So it appears to undergo oxidative demethylation by the enzyme, that is CYP3A4. Then urinary excretion is only 10 to 20%. The plasma T half is 9 hours. The drug is contraindicated in patients with hepatic or renal impairment. So adverse reactions of the colchicine, it include, it produces GI upset and the diarrhea very commonly. Occasionally it may cause anemia, alopecia, leukopenia and agranulocytosis. Prolonged therapy may rarely cause myopathy, that is proximal muscle weakness, but incidence increases in patient taking statins and the fibrates. Because of troublesome diarrhea, some workers prefer Indomethacin to colchicine in treatment of acute gouty arthritis. Okay, so therapeutic uses in treatment of acute attacks of gouty arthritis, it is used. So it is administered orally using single dose of 1.2 milligram, which is followed by 0.6 milligram 1 hour later. It relieves pain in most of the cases within 24 to 48 hours. If taken early in the attack, it can relieve the attack within a few hours or even abort it. So the therapy must not be repeated within 4 days to avoid cumulative toxicity. So once patient takes this drug, he should wait for 4 days for the next dosing period. Okay, so colchicine may be used for a therapeutic trial when the diagnosis of the gouty arthritis is in doubt, because the response to the colchicine is specific to the gout. Okay, so this sentence is very much important, because if the doctor is in doubt that the person has the gout or not, so in that case the doctor can start the patient on the colchicine. The reason is that the colchicine, it only affects the gouty cases. That means the patients who are suffering from the gout, only those patients will have any effect of the colchicine. In other patients in whom there is no problem of the gout or there is no gout at all, in those patients this gout won't have any effect. Okay. So next therapeutic use is prevention of acute attacks of gouty arthritis. So prophylactically administered in small doses of 0.6 milligram twice daily for 6 months, it can reduce the frequency of attacks in patients having 3 or more attacks in a year. So prophylactically administered means what? There is no presence of acute attack, but still if we administer the colchicine, then it will prevent the upcoming gouty arthritis attacks. Okay, so for chronic use in small doses, it is better tolerated than NSAIDs. Okay, so NSAIDs, as it has some other adverse effect that we have enlisted in yesterday's lecture only. So for chronically we can use colchicine when compared to the NSAIDs. So prophylactic colchicine, it prevents precipitation of acute attack by surgical procedure or by initiation of the hypouricemic drug therapy. So next therapeutic use is prevention of attacks of familial Mediterranean fever, that is familial paroxysmal polyserositis. Okay, so in this condition also we can use the colchicine. So Indomethacin, that is the NSAID used in acute attacks. So this NSAID in the dose of 25 to 50 milligram TID for 5 to 7 days can promptly relieve the pain which is associated with gouty arthritis. However, the incidence of gastric intolerance is high with the use of Indomethacin. The drug can also be given as 100 milligram suppositories to avoid the incidence of gastric intolerance. Then naproxen or ibuprofen, they are equally effective and they are less toxic when compared to the Indomethacin. So glucocorticoids, they can be used in very severe cases which are refractory to the colchicine and NSAIDs. Refractory means not giving any response to the colchicine or NSAID therapy. So their action is not specific and the relapse rate is very high. Relapse rate means what? If we stop the patient on the glucocorticoids, then the gouty arthritis signs and symptoms, they will reoccur. Okay, so prednisolone, it is given in the dose of 20 milligrams that BID till the patient is asymptomatic for 1 week and then is progressively reduced by 5 to 10 milligram every day. So this is nothing but the tapering of the doses. Okay, so in case of the glucocorticoids, it is very much essential. What is tapering of dose is that once we start the person on the glucocorticoids, we have to as the symptoms are relieved, we have to decrease the dose of glucocorticoids stepwise. We should not stop the person on the glucocorticoids suddenly. Sudden withdrawal of the glucocorticoids, it is not advisable, as the probability of relapse is very much greater in the patients who are on glucocorticoids. So when a large joint such as knee joint is affected, aspiration and intra-articular injection of the hydrocortisone acetate, methylprednisolone or the triamcinolone, it may give dramatic relief. Okay, so drugs which are used in long-term therapy of the gout, These drugs are indicated when any of the following criteria are fulfilled. The first criteria, the cause of hyperuricemia, it cannot be corrected, or such correction does not lower the plasma urate to less than 7 milligram percentage. Okay. Then second is the patient has had at least 2 definite attacks of acute gouty arthritis or has tophi in the soft tissues. So patient agrees to take the medication regularly, almost lifelong, and acute attacks with serum uric acid levels of 9 milligram percentage or higher. In these cases, we have to think about the long-term therapy of gout. So drugs which are used in long-term therapy of gout, they act by reducing the plasma urate levels either by excreting uric acid, that is uricosuric drugs, or by preventing the uric acid synthesis, that is xanthine oxidase inhibitors. Okay. So these drugs which are to be used in long-term therapy, they do not prevent the acute attacks, but they decrease the frequency of the attacks and may diminish the incidence of renal damage and other complications which may happen due to urate deposition. Reduction of the plasma urate levels to less than 6 milligram percentage is required to prevent acute gouty arthritis and less than 4 milligram percentage for reabsorption of the tophi. So pathological readings, they must be correlated with the use of drug therapy. So depending on the urate percentage, milligram percentage in the body, we have to decide on the therapy. And if we have to work on the reabsorption of the tophi, so in that case we have to decrease the levels of the uric acid in the body below 4 milligram percentage. Okay. So initial treatment is always with uric acid synthesis inhibitors. If they fail, then uricosuric drugs are supplemented with it. Okay. So we have to start with the uric acid synthesis inhibitors, and then if these drugs are unable to do the justice, then in that case we have to go for uricosuric drugs, or we have to add it to the therapy. So therapy to reduce plasma urate levels, it should be started only after the subsidence of the acute joint inflammation, as otherwise it may delay recovery from the acute attack. So this is very important. We have to start the therapy only when there is a symptom free period, like there is no acute joint inflammation is there. Otherwise it will delay the recovery. Okay. So we have to first of all work on this, that is we have to decrease the acute inflammation, and once it is decreased, then we can start with the therapy. So however, pre-existing therapy with plasma urate lowering drugs, it should not be stopped in case of an acute attack. Okay. So if started in interval between acute attacks, it should be preceded by prophylactic treatment with the colchicine, as rapid lowering of the uric acid sometimes precipitates an attack, probably due to mobilization of uric acid from the tophi. Okay. So even if we start with this therapy, we should not stop the colchicine, as there is probability that the uric acid levels, as they go on decreasing from the joints, whatever uric acid which is deposited in soft tissues as the tophi, it will be released into the circulation and it will be mobilized again into the joints, and again it will give rise to the acute gouty arthritis attack. So prophylactic colchicine, it should be continued for 1 year after the plasma urate level has returned to the target level. Okay. So we have to continue giving the colchicine for the 1 year when the target is achieved. Okay. So drugs that prevent synthesis of uric acid, that is xanthine oxidase inhibitor, and the name of drug is allopurinol. So it is 4-hydroxypyrazole 3,4-D pyrimidine structure. You can see the structure over here, and it is useful for long term management of the gout. So mechanism of action: during purine metabolism, the purine nucleotides, they are degraded to hypoxanthine and xanthine, which are then oxidized to uric acid by xanthine oxidase. Allopurinol and its metabolic product, that is alloxanthine, that is oxypurinol, it inhibits xanthine oxidase, and hence they inhibit oxidation of hypoxanthine and xanthine to uric acid. You can see in the reaction below. They lower the serum and urine uric acid levels, then they reduce size of tophi, and they increase the excretion of hypoxanthine and xanthine in the urine. Okay. So in presence of xanthine oxidase, this allopurinol, it gets converted to alloxanthine, and this alloxanthine is responsible for inhibition of the xanthine oxidase. So this is example of suicide inhibition. Okay. So you must have studied this particular example in the biochemistry course. So adverse effects of the allopurinol, they include, the incidence is around 15 to 20%. Most common, they are the allergic skin rash, nausea, vomiting, diarrhea, leukopenia, hepatic damage, and vasculitis, they can also occur. Then hemosiderosis, it is a rare adverse effect, but it is a serious complication. So other severe ADA, they are the toxic epidermal necrolysis, then bone marrow suppression, and the ototoxicity. So therapeutic uses of it in the gout: it is used for controlling hyperuricemia. It is useful in patients with gouty tophi or uric acid calculi, and in those with renal failure, which renders uricosuric drugs less effective. Okay. So uricosuric drugs may be started as initial therapy in patients who have urinary uric acid excretion less than 800 mg of the uric acid per day but have normal renal function. Allopurinol may be combined with the uricosuric drugs. So in secondary hyperuricemia also we can go for the allopurinol. This occurs following the use of cytotoxic drugs in treatment of the leukemia and lymphoma. So therefore allopurinol is started before starting the chemotherapy. Inhibition of the xanthine oxidase, which also metabolizes 6-mercaptopurine, it prolongs its T-half, and hence its dose is used to 1/3 or 1/4 to avoid serious toxicity. So these mercaptopurine drugs, they are very commonly used in the chemotherapy that is of cancer, and that's why if we are giving allopurinol along with it, we have to decrease its dose to avoid the toxicity. So then next drug we have, that is febuxostat. So it is orally active non-purine analog of allopurinol, and it acts as an inhibitor of xanthine oxidase. So it is well tolerated, and it can be used in patients who are allergic to or intolerant of the allopurinol. Okay. So maximum daily dose is 80 mg, and it is mainly metabolized in the liver. So mild to moderate renal insufficiency does not alter its serum uric acid lowering ability. So its ADR include liver function abnormalities, headache, nausea, and Stevens-Johnson syndrome. Okay. So next drug we have, that is Rasburicase. So this Rasburicase is a recombinant urate oxidase which causes enzymatic degradation of uric acid to soluble allantoin. So it is usually used to reduce the elevated uric acid levels in tumor lysis syndrome, that is TLS, and which is seen following cancer chemotherapy. Okay, so its ADR include vomiting, fever, headache, GI upset, mucositis, acute renal failure, anaphylaxis, and hemolysis in G6PD deficiency patients. Okay, so a very specific use it has, that is in patients who are undergoing chemotherapy, there will be lysis of the tumors, that is tumor regression is happening, and this tumor regression is leading to the uric acid in the blood, and to decrease that elevated uric acid levels, in that case this drug is being utilized. So next drug we have, that is Pegloticase. So this Pegloticase is pegylated mammalian recombinant uricase, which is produced by genetically modulated strain of Escherichia coli. So it is used for treatment of chronic resistant gout. So the ADR, they include infusion reactions, anaphylaxis, development of anti-pegloticase antibodies. Okay, so why the antibodies they are created for pegloticase is that it is a recombinant product. That's why the body tends to identify it as a foreign body which is trying to attack our body, so the antibodies are produced against it. So next drug, that is Uricosuric drug, example is Probenecid. So it is given orally. It is given initially in dose of 0.5 grams once daily and gradually increasing to 3 times daily. So in low doses it causes decrease in distal tubular secretion of uric acid, but in larger therapeutic doses it increases its excretion by blocking tubular reabsorption. Okay, so in low doses its effect is different, in high doses its make of action is different. So after treatment for some months, serum uric acid it may return to normal levels together with significant mobilization of gouty tophi. Okay, so next, adverse reactions of Probenecid. The drug is relatively non-toxic and is well tolerated. Occasionally it causes dyspepsia, skin rashes, and deposition of urate crystals in the renal tubules or pelvis. So this risk can be minimized by maintaining a high volume of alkaline urine with 1 gram of sodium bicarbonate orally 3 to 4 times a day. Okay, so the drug inhibits renal excretion of drugs such as penicillin, Indomethacin, methotrexate, and dapsone. So in this case we have to decrease the dose of this particular penicillin, Indomethacin, methotrexate, or dapsone. So what will happen? If we give these drugs in normal therapeutic doses, then it will cause its deposition. So it also impairs heparin metabolism, thus reducing the dose of heparin necessary for anticoagulation. Okay, so next drug that we have, that is Sulfinpyrazone. So this is a sulfoxide derivative of phenylbutazone with some anti-inflammatory activity but marked uricosuric property. So this effect is dose related. Like Probenecid, its smaller dose it prevents tubular secretion of uric acid, while higher dose it promotes its excretion. It is administered orally in dose of 100 to 200 TID. So daily dose should not exceed 600 milligrams. Okay, so Sulfinpyrazone, the adverse effects of it include vomiting, upper abdominal discomfort, and skin rashes. Rarely it can aggravate existing DU and may cause bone marrow depression. Okay, so sulfinpyrazone, it inhibits platelet aggregation. Okay, so next drug, that is Azapropazone. So this uricosuric drug has weak analgesic, antipyretic and anti-inflammatory action. It is a weak inhibitor of cyclooxygenase enzyme. So the drug is rapidly and almost completely absorbed from the gut. It is relatively toxic. The common ADR comprise mild GI effects and the headache. Dose in acute gout is 600 mg 4 times on the first day, followed by 1800 mg a day in divided doses until acute attack has subsided. The maintenance dose is 1200 mg a day in divided doses. So it has also been used for treatment of the rheumatoid arthritis and osteoarthritis. So the contraindications of the uricosuric drugs, that means we should avoid these drugs in the conditions like the urate overproduces, the 24 urine urate more than 800 mg, those with urine flow consistently less than 1 ml per minute, then those with creatinine clearance less than 50 ml per minute, and those with history of renal calculi, we have to avoid the uricosuric drugs as they will prove to be hazardous. Okay, so with this we have finished with the chapter, that is drugs which are used in treatment of gout. Okay, so that was all from my side. Thank you.